The thing that makes it special for us is that it explicitly talks about substance and trauma, how they interconnect, how they're separate, how they all go together, how one can impact the other, and vice versa.
I am a community case manager working in inner city hospital, helping people that struggle with addiction.
Great. So my name is Wip Lamba. I'm a psychiatrist. I mainly work with people who use drugs, hospital setting, and relevant to this talk is I try to do some work with trauma, right? So I try to do some kinds of trauma therapy and PTSD treatment, but it's obviously I'm a bit of a beginner compared to some of our colleagues where it's their life work and their primary focus.
Okay. And so leading into that, so the topic today is...
So today we're going to talk about seeking safety.
Okay.
It's an evidence-based psychotherapy developed by Lisa Nahavitz, who's a psychologist in Boston. And she developed this therapy, I don't know if it was like 10, 20 years ago at least. And it's a therapy that I really believe in, and I've seen it help tons of people that we work with.
Okay.
So for me, when I started working at that hospital that you're at now, we had a rapid access addiction medicine clinic. We had psychosocial groups, and we see people in hospital. And because a lot of the people we were seeing were ones that were coming through the hospital stream, the two things I found around those patients was that they had high levels of medical complexity and they had low levels of motivation. And so it's almost like this place where when you hook somebody in, they build a relationship with you, it's hard to get them to go to other places. And back then, there was a women's college hospital, which is primarily an outpatient hospital, had a seeking safety group for women.
Okay. And
Fred Victor had this program for concurrent disorders. It was run by Carol Lessard, who was a phenomenal mentor and guide for me as I was learning this therapy, who also had another group for women.
Okay.
And so I was stuck with, well, I shouldn't say stuck, but I was working with people doing groups and addiction medicine and some psychiatry with a lot of men that had trauma, and there was nowhere that I could send them. So for the different trauma programs around in the city for PTSD treatment, usually there's 3-6 months, a year wait list. Sometimes they'll require for you to have 3 to 6 months of sobriety before they'd even consider you. And sometimes if you have a strong personality disorder symptoms, you have regular substance use, safety issues around self-harm, they won't even accept you into their program. And so I had nowhere to send these men to. And the stereotype, which is not entirely true, but the stereotype you sort of be taught and you sort of hear about would be that, some people, they use the substances to cope with their trauma. So maybe they have nightmares, maybe they have flashbacks, maybe they don't feel safe. And the drug use puts them in a state where those symptoms don't bother them as much. And then when you enter the detox and go through the detox process, you're stuck with those symptoms and you don't know what to do with them.
So what I'm hearing is kind of the irony of the existing programs at the time is that the people that needed it the most couldn't get it. Is that another way of saying it?
No, but that's very standard, right? So for all our patients who use drugs,
it's true.
No, think about it. Think about the post-acute rehab facilities, right? It's an exclusion criteria. But if one of us broke our leg and we would benefit from rehab, we would do well there. But wouldn't our patients who broke their legs, who have addiction issues, need that rehab more?
Yeah.
Right. And so this is a very common issue. And in fact, we haven't talked about this, but one of the reasons I love addiction work is I'm helping all these people get access to psychiatry. So historically, psychiatry wouldn't always see these patients. They say you have to treat your addiction first. But I mean, by doing this work, I'm getting access. They're getting access to treatment for bipolar disorder, for schizophrenia, and for PTSD. And you can I talked before about that Bessel van der Kolk book, right? Around the different therapies, the evidence-based treatments for trauma that I'd never heard of. Can you imagine when I found out there was an evidence-based treatment for people that have trauma and addiction, and I'd never heard of it? And I'm out in practice for a couple of years. You know how embarrassing that is?
Yeah.
And then you start talking to people who implement it, then you don't have a place to send your men.
Right.
Right? You don't want to place on your men. And there were a couple of programs back then that I could send them to. There was one place that allowed for men with sexual abuse to go there, but it was just so intense, right? So they had to sign up. They had to, like, it's just, like, it was really, really deep work. And the reason that I got excited about Seeking Safety was because I had colleagues at Women's College and colleagues at Fred Victor that were running these groups for women. So I had like mentors, and the therapy is very, very low barrier. Like, it's very low barrier. And so when you hear Lisa Nahavitz speak about it, she studied with psychologists running groups. She studied it with people that just have a high school education, them running groups. She studied it with people that are homeless and nomadic almost, in how they live. And she's also studied it with people that are like high functioning, full-time employed, whatever that means, And so
So if I'm sorry to interrupt, but am I hearing you right? So then this is a type of group that doesn't have to be run by a psychologist or psychiatrist?
No, and she also has it designed so it can be run by peers.
Okay.
She studied so that if you've had a lived experience, you've been through the group, you can deliver the group.
Okay.
Right? And when it hit all those things around that low barrier, because look, if I want to do CBT, I mean, it's a bit different as a psychiatrist in Canada, but say if I was a social worker, right, I want to do a specific kind of CBT, I have to go through all these accreditation processes for it, and it's just not realistic at this stage in my career to do all those things. I mean, it's sort of a blessing and a curse in a way. It's a blessing that there wasn't those programs for men, because if there was a program for men that I could have sent them to, I just would have referred them.
Okay.
Right? But I mean, the other problem was, even if I refer them, who knows if they would have gone there, right? Because sometimes people build a relationship with you. So I found out about this therapy. I read about it. It is a bit controversial, right? So what makes it controversial is that if you read about any treatment for post-traumatic stress disorder, like any guideline, they'll say Seeking Safety is not a treatment for PTSD.
Okay.
Right? And so that's where it gets a little bit sort of confusing, but it's very good for substance use. And there's very good outcome measures that may not be directly related to the PTSD symptoms, where it's quite effective for. And so what I did was I reached out to Lisa Nahavitz's company, Treatment Innovations. I figured out what the cost is. They do this partnership thing, where they charge a certain amount, and then you keep whatever 50% of whatever those profits are. So we started recruiting. We set up a 2-day training in Toronto, where she had one of her former grad students come from California for 2 days. It was a 2-day training. Half of them were people at our hospital or community partners, and the other half paid. And I got so lucky because the chief of psychiatry at that time realized that the way I said it, I was going to lose like $3,000 in setting it up. I was almost going to cancel it, right? Like it was like 3 weeks before. I was like, I'm going to lose like $2,000-$3,000 in this, And then my friend Tim was like, "You've committed to this." Like he has this way of saying things that just calls you on your crap, right?
Mm-hmm.
And so I committed to. So we ran the training. There's about 50 people that attended. Most of them were covered, and then my chief was nice enough to use her discretionary funds for the difference. And then as an adult learner, and you might have found this yourself, you can't just go to a training and pick up a skill set. Like I just knew that wasn't realistic. So instead of going to there for the training, this was back when they had less online stuff, had her come down here, trained myself and several colleagues, that even had our admin attend as well.
Great.
The training as well.
Yeah.
Because you really want to build that compassion, right? Shift that language from what's wrong with you to what's happened to you.
Right.
That's making you respond like this. And for me, this is trauma-informed care. When I see what Seeking Safety is, for me, this is what trauma-informed care can be, could be, should be, would be, all that kind of stuff. And that's why sometimes when I give a trauma-informed care talk, I talk about Seeking Safety. So we had the training. I had 3 or 4 close colleagues come to the training who I knew were going to be running groups with me, right?
Yeah.
So we had one colleague who worked at the detox, running their day program there. Yeah. We had one colleague or 2 colleagues that were recommended from Carol Lessard. They worked for different community agencies where they got permission from their boss to go to the 2-day training and join us for a while. And then the other thing that I got lucky for is that my boss gave me support where I could just book rooms. I could just book rooms at the hospital. And so every 3 months for about a year, I ran a community practice. So all the people that attended, there was about 50, 60 people at the first training. And then every 3 months, about 30 of us would get together, and then we would just practice. We would just practice. We talk about what worked, what didn't work, all that kind of stuff. When Lisa Habits does a training, she says that usually the patients feel better by session 2. If you have just by picking up the book, reading it, and doing it with a patient, usually by session 2, the patients feel comfortable, usually the therapist by session 4.
Okay.
So she believes you don't actually need the full training to do it. She says she studied it the way that it is. And now with everything on COVID, it's like a couple $100 and you can just get a day of virtual training, and then you can roll it out in your practice. So before the training, what I did was I picked a couple of chapters. I had a couple of patients I was working closely with, and I asked them, hey, would you be okay if we did a session on seeking safety? We'd cover this skill or that skill, and then I practiced sort of with them. And then with Chris, who ran the day program, and a couple of other people, we set things up so that we'd be running it at 2 sites. And so we would have it a certain day of the week. We would have certain things where we had this intro feeder group where it was like 6 sessions where people could come at any time, or 4 sessions, they could come at any time. Once someone's come to those 4 sessions, they can go to the 6-week or the 12-week course. So we had sort of different stages for it as well. And we kept it running for about 2 to 3 years for it.
And I know that since I work with Chris Lopez, he's still got that going. Amazing work that he does there.
He's so good.
So this is you planted that seed, I guess, probably 4 or 5 years ago at this point now, and it's growing into
also the thing
little
is
bit of an oak tree.
He's a very good group therapist, right? Yeah. And I just know he works in settings where he can't predict how intoxicated people are going to be, how vulnerable people are going to be, people that might share too much and not come back, share too little, not come back, people that might be scared. And he has a way of keeping certain people in. And he's also very good at spinning plates, right? Mm-hmm. So getting people to talk, include everyone, and also making sure that nobody shares too much, but they feel validated, all that stuff. And so, like, one of the best ways to run a group is to have an all-star therapist beside you.
Yeah, absolutely. No, I've sat in a couple of his groups, but and just the work that he's able to do, like just you're right, very independent. Kind of a group. Sort of like a combination of one-on-one therapy and group at the same time, right? And he's able to sort of, I guess that's your spinning plates analogy there. But also the feedback we get from participants is just so amazing, and he has such a great following. So I didn't know that was the origin. So that was the origins of his work with Seeking Safety.
Well, he does a lot of different groups, right? So
no, but the Seeking Safety work was how it started.
We did the 2-day training. Yeah. Then we'd had every 3 months we had this community practice that would meet. We had them come back for an advanced training, and then at Casey House back then, there was a very skilled social worker that ran their education program, and then she got them to come back a couple more times a couple of years later.
Okay.
And then there's this Dr. Teresa Marsh. So she's a psychologist. She did a PhD with Lisa Habits, and she actually took Seeking Safety and took Indigenous healing and combined it. So she has a version that's designed for Indigenous patients as well. So I don't know, it's just such a great therapy. And even though I didn't talk about it today at all, I think our trauma-informed care really covers why this is important.
Yeah.
And for me, being in evidence-based psychotherapy feels like we're offering more than just helping people be more patient-centered and more compassionate, right? It's like an actual sort of protocol. So...
Right. I mean, the one question I had, if I could, so relates to you earlier. You said that this is not. You said they say. I don't know who the they is in the sentence. That this is not a good treatment for PTSD.
Yep.
Why not? And then what is it if it's not treating PTSD? What's it treating?
Yeah. So what is PTSD? PTSD is a DSM diagnosis, or ICD-10, whatever. And it's a cluster of symptoms that cause dysfunction in several areas in their life. Usually people have a traumatic event or they have vicarious trauma, and then they'll have nightmares, flashbacks, all these kinds of things. And in order to fully sort of treat PTSD, there's a whole group of psychologists out there that don't actually believe in this stage-wise trauma approach. So when you're talking about trauma treatment, there's this Judith Herman approach of stage-wise trauma treatment. So the first part is creating safety. The second part is mourning or processing the trauma. And the third part is recovery or connection to the world. And some people believe that unless you achieve safety, you can't go through the mourning process. And this therapy is designed by those that believe in those stage-wise process. So if you talk to people who've developed psychotherapies for PTSD, like Candace Monson, who's developed cognitive processing therapy, she believes that a lot of the tools used in seeking safety, you're actually avoiding the issue and you're avoiding the meat. The challenge is that with actual PTSD treatments, the dropout rate is through the roof, right? So when I trained in and I offered cognitive processing therapy and I talked to my colleagues about it, usually they'd have about a 50% dropout rate. And in the studies, it's usually between 20 to 40%, depending on what you look at, right? And for us, every patient's important. And a lot of these people don't trust anyone. They've never been in a public place, especially for the men, I find. They don't share any of the stuff they've been through. And so for me, just getting people to show up regularly, the substance use clearly goes down. And I think there's other metrics where the evidence is there. And I'll include the links in the commentary. But there's very clear studies and evidence that this therapy works and helps. It might help with some of the symptoms of PTSD. It definitely helps with the substance use. Maybe people feel more meaning or connection to things. It can get people attending and showing up on a regular basis to other programs and other services. So I think like... maybe now was not the right time, but it is a controversy in terms of what is proper PTSD treatment, what's complex PTSD versus PTSD, what are the treatments for that. And I think the best way that's not controversial to look at seeking safety, it's a treatment for trauma and substance use, not necessarily PTSD. And for me, I always use this as a trauma-informed care lens, not to say anything wrong towards the people that really believe in those key PTSD treatments. You know, I don't want to give mixed messages.
Can you walk us through what one of these sessions would be like? Like, give us a sort of an example.
Yeah,
somebody
absolutely.
Who's never been to one or doesn't really know anything about
and
it.
So the great thing about these sessions is that they're very, very structured.
Okay.
Right. And, you know, one of the things that people with trauma sometimes have, they're always scared in terms of what's going to happen in the session, what do I have to share, all that kind of stuff.
Yeah, for sure. It sounds super intimidating.
Yeah. And so each session is almost the exact same.
Okay.
And so it starts with a check-in, and there's three check-in questions. I guess, you know, you share your first name, you share how you feel, any unhealthy coping, and healthy coping, like healthy, unhealthy coping.
That you've done in recently, is that?
Yeah.
Okay.
Yeah, within the last week.
Okay.
And then the third question has to do with any connection to community resources.
Okay.
Right. Or did you do your homework, or did you connect some community resources? So even though it's sounds
a little bit like a CRA maybe check-in. No, have I got that right?
Well, all the check-ins are similar.
Okay.
Right. All these check-ins to groups are sort of similar, and as facilitators, you can decide what that check-in is. But for her, it's actually quite protocolized, right? And if you want, we could even put that up on the slide deck. I can send that to you. There's a sheet in the book that's right there for it. And so you have those three questions to check in. And then you have a quote.
Okay.
Right? And the quote can be there's about 25 different units. But you can have a quote. And a quote could be like, if you don't risk anything, you can risk it all. Or something along those lines. And then you'd ask the group, you know, what does that mean? And the group will say, I think it means this, I think it means that, and then you can validate, you can shift. And the best part about the book is, even though it's dated, it's like 2 decades old, when there's something where the language doesn't match, like say if they use more abstinence-based language, or they use terms that are a bit like have different connotations, you can create that as a space for dialogue. So they have the quote, and then you talk about it, and the quote usually links to what the content is. And then you do a grounding exercise. Okay. Right? Or maybe you do the grounding exercise before the quote. I think it depends, but maybe the grounding exercise before the quote. And it's basically you can either go through a script that takes about 10 minutes, where you go through 3 forms of grounding. So you go through either mental, physical, or favorites, or all 3. And then you go through the content, and the content will have different themes like safety, like thinking, like power. I mean, they have one session where they just define PTSD, and for me that blew me away, because for me it was just so obvious, right? So it was post-traumatic stress disorder. We see it all the time. But when they gave a definition of post-traumatic stress disorder as after trauma stress reaction, I saw all these men's eyes lit up. Oh, so that's what it is. Oh, that's what's going on. No wonder I'm always on guard. No wonder I don't feel safe anywhere. No wonder I don't like talking to people. No wonder I cope this way. And it was just magic seeing all these men just talk and share and go through some of these things.
Okay, so just to sort of pull that back together, so it's that could be a whole session then. So you've got the check-in, right? And then you've got the
mindfulness exercise.
You
have the quote. What does that mean? And then
the
you have
quote,
the
which is
handouts.
what the presenter is going to present the quote.
Yeah.
And then you're going to discuss that quote, and everyone's free to share what that means to them.
Yep.
And then but so what I didn't hear in that is nobody had to share any of their past traumas in that.
Yeah, because you make it very clear in the beginning. So in the beginning of the group, you go over the group norms, and one of the things, it's headlines only.
Okay.
So it's sort of like CRA. Like when we do CRA, we say, hey, it's chocolate cake. It's not like this hot fudge, whatever.
Yeah.
And with the trauma, it's really just headlines only. And sometimes you have to pull people back if they start sharing too much to remind them that it is really just around the headlines. So for all these groups, you do want to set up group norms as well.
Well, I think that's really helpful for people that might be interested in checking it out, that may be resistant to checking it out, right?
Yeah,
wouldn't you
absolutely.
think? Because, do I have to talk about that, right? And the answer to that is no. In fact, it's not even something that's encouraged. Is that or it's something that's discouraged, I guess?
Yeah, it absolutely is, right? Because this is not...
It's definitively discouraged.
Well, I mean, this is why they call it not a treatment for PTSD, right? Because you're not actually going through the trauma.
Okay.
You're helping people create safety in their day-to-day lives.
So looking at the now and the future.
Yeah, you're helping them have some compassion for themselves, given that, they've been through trauma, and you're helping them cope through their day-to-day lives and knowing that that's what they've been through. So it's going to be shaped differently, right? If I go for a walk at 7 p.m. At night and it's dark outside and I've not been traumatized, I'm going to be fine with it. But if it's somebody else, they might avoid doing things in the evening. They might not feel safe. They might not be able to do any of those kinds of things. And so it's all these strategies to reduce that suffering. And so, for example, they'll have certain sessions where it's more about leaning in, right? Like, oh, I don't feel safe. I should try to do that. But some people with trauma, they do the opposite. They have no boundaries, right? And so they'll also have sessions on how do you set those boundaries, right? And so it's really about giving this whole set of skills to different patients, and then they get to pick and choose the ones that are relevant. I'll give you some examples, right?
Sure.
So for example, you know how I said there's a quote and then there's handouts? So one session could be on safety. It could be on detaching from emotional pain. It could be on asking for help. It could be on compassion. It could be on red flags and green flags. It could be setting boundaries in relationships. So there's 25 of these topics, right? So when we were setting it up, we would pick 4 to 6 core ones as our intro group. If we had that commitment and we decided we were doing a 12 or 24 week, then we would actually do the full sort of thing where we'd pick those topics there. Sometimes we'd let the group members pick. But after people are done, they're normalized to coming to a group environment. They know the rules of engagement in the group there and afterwards and after they leave. They know what it's like for them to be in situations where they might be vulnerable and how to reach out for help. It's heavy based on case management.
Yeah.
Like it's just every single session you're talking about what community resources have you checked in? What are you planning on checking in this week?
Okay.
Right? And embedded in these sessions, sometimes the ones where it's more CBT skills, sometimes it's more behavioral, sometimes it's more communication, sometimes it's more just explaining what's going on in that mind and body because of all the crap that you've been through.
Okay. So the commonality of everyone in the room is they have experienced some past trauma.
Yeah, I mean, we don't make it mandatory, right? Because it could be a big T, small t, whatever.
Sure.
Well, we let them know this is a treatment that's designed for substance use and people that have had trauma.
Right. And do we call that concurrent then? Is that what concurrent?
Yeah, you could call concurrent. I mean, in Canada, like they use concurrent disorders for people that have a mental health and an addiction diagnosis. In the States, they use the term dual diagnosis, for it. And so I think the words are important because people will use the same words to mean different things. I guess you could call it concurrent disorders. I just really see it as,
well, forget about the language.
For me, this is trauma-informed care. For me, this is trauma-informed care
right.
for people that have trauma and people that use drugs, or they had trauma in the past and they use drugs. But even if you have one but not the other, you can still get something out of these sessions.
So they've got the commonality of these past traumas and the substance use together, and they're learning a set of tools that it's kind of an a la carte thing, whatever kind of work for you, and coping skills, I guess,
Absolutely.
is the
That's
best way.
Exactly it. Yeah.
And it's focused on the now and the future and not necessarily talking about what happened 20 years ago.
Yeah, just headlines for that.
Headlines.
Yeah, and the thing is, you know, when we first ran these groups, we made sure everyone was connected to somebody individually as well. So they'd have separate individual sessions, and it was really helpful for us when we started, because, you know, sometimes you'll have people that talk a lot or talk a little or stuff that would be triggering for others, and then you sort of get a feel for what's working and what's not working.
Yeah.
And I think the same thing happened with COVID, where you had to make certain adaptations to it, right? Because it's a very different experience virtually.
Now, the one thing I found interesting from the little bit of research I did before is some people are in this program, if it's, you know, working for them for quite a long period of time. Is that?
Yeah, it depends on how people structure it, how it's offered. You know, I'm convinced that with a lot of these skill-based psychotherapies, it's the third time through the content that people really get it. But that's just my gut feeling. And I think if it's offered, I think it's very worth going to. I mean, there's going to be some patients or some people where it's probably better for them to go to more sessions. Some people where it's better for them to go to less, but it all depends on how it is. And because it's so structured, right? You could either be like a phenomenal therapist like Lisa Havitz. If you watch some of her videos, she creates these cathartic moments, right? And whereas for me, I'm not at that level. So for me, it's more just about creating the space, making sure they pick up the skills and making sure they come back. And there comes a point when people have been through 12 or 24, they're like, hey, you know, this isn't enough. You know, I don't want to just talk about headlines. I want to deal with this crap. I don't want to keep having these repetitive relationships that are bad. I don't want to be avoiding things that are meaningful and important to me. They're like, I actually want to do the trauma treatment. And so for me, all the deep dives I've done have started with patients where I didn't have the resources to connect them to. I had to learn the skill. I figured out quite early on that if I learn a skill, but I don't have a community of learners or people to check in with or people or a mentor to guide, there's no way that I can do it in a sustainable way. And then good or bad, once you start doing that and you roll it out, then you find the next problem down the list. And the next problem was that these people actually wanted PTSD treatment.
Okay. So for some people, that's the next step.
Yes.
Is to do that.
Yeah, and it's their choice, right? It's just like when you go to the beach, right? Like you can decide if you just sit on the beach, you can decide if you put your toes in, you can decide if you dive in and walk out, you can decide if you tread, you can decide if you get a jet ski and go deep in the water. And we really want to make trauma treatment like that for people. We want to make trauma treatment such that they know, like, whether or not there's a diagnosis or not. They know the risks and benefits of the different treatments and the timeline and when to go through it. And you want to give them a menu of options, right? So the ideal program would actually have a menu of options where people could pick what therapy path they want to go through. I don't think there's any value in forced trauma treatment, and I think you'd agree with me for that. But we don't give enough breadth of evidence-based options for people we're trying to serve.
Okay. All right. Well, so that's the next stage for some, but for others, Seeking Safety does it. Is that right?
Yeah, and some people don't want to go deeper. Some people are just like, oh, no, this is great. I get what's there. You know, I'm functioning better on a day-to-day basis now. These skills are very, very helpful for me. And some people would benefit from other things, you know, more than the trauma work, right? They might benefit from dialectical behavior therapy. Maybe they need more addiction work, more intense basic addiction work. Maybe they need to be involved in something where they're living their life and having meaning and stuff in it as well. And maybe part of it is because some of these other therapies aren't easily offered either, right?
Right. Now, since we do talk about addiction here, this is our kind of wheelhouse. So how is this therapy does the addiction sort of, it's kind of addressed not really addressed directly in a way, but also kind of these skills sort of build on it. And if you've got these coping skills, I guess the backstory of that is that many people think the addiction is replacing something that is being created by these traumas. Is that fair?
Yeah. Why don't I go through the core concepts of treatment? You know, I'll just list them off.
Sure.
Right. So they have a handout. That's the core concepts of treatment. It's one thing you give people in the first session.
Okay.
The concepts are: stay safe, respect yourself, use coping, not substances, to escape the pain, make the present and future better than the past, learn to trust, take good care of your body, get help from safe people. To heal fully from PTSD, become substance-free, If one method doesn't work, try something else. Never, 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 never give up. And so they have sort of these quotes, and a lot of the stuff, I mean, we've talked about this, a lot of it is about how to improve your life, right? How to improve your life. And the more you improve your life, the substance use is going to go down. The thing that makes it special for us is that it explicitly talks about substance and trauma, how they interconnect, how they're separate, how they all go together, how one can impact the other, and vice versa. And so in these sessions and these handouts, they'll have some teaching points and they'll have exercises people do. And then when you're doing it, it depends on the audience, right? So a colleague of mine she used to do it sometimes with people with developmental disabilities, right? And well, how do you convert that to that? You take whatever the content is, you simplify it, right? Sometimes you'll read the session out loud. Other times we have people with your level of intelligence and processing, we'll have them just read them on their own, like 5 minutes, and then we'll just do the exercises out loud as a group, right? Or I've had some sessions where it's like 15 minutes, people are just doing the exercise, right? And so there's all these ways to adapt the content so people leave with those core skills, and it's made explicit. Substance use, trauma, how it all interacts and goes together.
Okay, well, good stuff. So that's a good first look at seeking safety.
Yeah, I feel like I wanted to share something more sort of special. Maybe it's because usually when I talk about seeking safety, my talk is usually on trauma-informed care, and then I just throw this in at the end as a hook, and but maybe what we can do is we can share some of Lisa Nahavit's podcasts.
Absolutely,
that we've really liked. We've got a couple of references for it, including her website if somebody wants to go get training.
Yep.
And we'll have a link to a couple of PDF handouts that she also has on her website that'll give people a nice little sort of overview. And I think for anyone who has somebody who uses or used to use drugs, has trauma, or in some kind of way, I think, and especially if you have this desire, like, hey, how can I help more? Right? Like, this person's showing up, how can I help them more? For me, this is a great gateway for people, right? And sometimes it's enough, like you suggested, like some people, this absolutely, for some people it's enough. For other people, it opens their mind to what the therapy could do for them.
Yeah.
Right? And what it's like to be vulnerable. So thank you for this conversation.
Yeah, thank you. And if you like our content, please like and subscribe. We post new content every week.
Oh God, we're gonna get on that the subscriber addiction and the clicks and views addiction, aren't we? We can't avoid it now.
And we'll have to have a topic just on that, maybe.
Oh, maybe. Okay.
All right. Thank you.
you.
Bye.
Yep.